So over the past decades that this meeting has been going on, an analysis of the mutations in T-cell malignancies has been of great value. However, many times, only a small proportion of patients' malignancies have such mutations, and often they don't direct us toward a new approach to therapy. I add to such analysis an analysis of disorders, activation of the signaling pathways used normally by T cells that have been abnormally taken over by the malignant T cells. And I will say that no matter where the mutations are in this system, the whole receptor signaling molecule, JAK stat, is needed, and that one can attack this with agents such as JAK inhibitors that act on JAK1 or JAK3. So if we look at T-cell malignancies, all the subsets that have been looked at have an activation of the IL-2 family of cytokines, JAK-STAT pathway. We see that when there is phosphorylated STAT3 or phosphorylated STAT5 in the nucleus. And this occurs in 10 to 86% of each of the subsets of T cells. Nevertheless, a meaningful proportion have activation and mutations of STAT3 or STAT5b. This mutation is not enough in itself to initiate proliferation. No, it only activates, it only increases the effect of signals it receives from above. So as a theme throughout, you need the gamma cytokine, you need its receptor, you need JAK and STAT, and the corollary of this is you can attack this therapeutically at the level of the JAKs. One looked upstream of the STATs and again found a meaningful proportion of every type of T-cell malignancy having mutations of JAK1 or JAK3. And again, they were not enough of their own, but only took signals from above in order to respond. So one needs both JAKs and STATs. We showed that with shRNA knockdown approaches. In each case, with cell lines, if we knock down STAT3, if we knock down JAK1, we caused the death of the cell line. It was addicted to JAKs and STATs. What about the receptors for the cytokines? One has shown in at least two systems that one must have the receptor for the cytokine, and it must not be mutated so that it doesn't bind the cytokine. That is, one can show in systems with activation of JAKs and STATs that only occurs if you have the receptors as binding areas for the JAKs and STATs, and so that you need the receptors. Furthermore, you can show in a number of cases the activation of this pathway is not due to mutations of STATs, is not due to mutations of JAKs, but is due to excessive production of these cytokines, IL-2, IL-15, IL-9. In adult T-cell leukemia, for example, the retroviral virus HTLV1, human T-cell leukemia virus 1, has an element in it called TAX, and this protein TAX stimulates the cell to make IL-2 and the IL-2 receptor, IL-15, the IL-15 receptor, and IL-9. So one can attack this type of leukemia at the receptor with a new molecule called BNZ1 that blocks just those receptor cytokines, or by inhibiting JAK1 alone or JAK3 alone. It is improper, inadequate to use the commercially available ruxolitinib, tofacitinib. Why? Because they have off off-target JAK2 inhibition, off-target toxicity. So due to that toxicity, they cannot be used in dosing strategies that truly inhibit the pathway and have success. Rather, one has recognized this, and pure JAK1 and pure JAK3 inhibitors have emerged. It is these that we will evaluate. These are already in the clinic, and thus I visualize a situation where one will use for these T-cell malignancies a pure JAK1 or a pure JAK3 inhibitor as one element of multi-drug treatment. That will not be enough because the tumors escape in the pathway, and we have shown that an inhibitor of BCL-XL, an inhibitor of mTOR1 and 2 can complement and add to a JAK inhibitor. So we're building a multi-agent approach, a novel approach not previously really explored for T-cell malignancies, based on the observation that so many of these have activations of the gamma cytokine receptor JAK-STAT pathway.